So thanks so much, Chalenda, for the introduction and this kind invitation opportunity to talk about an update on the treatment of acute leukemia. As far as disclosures, I've received support from several pharmaceutical companies for work related to the development and testing of new drugs for acute leukemia, and I've done consultancy work in this area as well. As you're likely very aware, this is a busy time when it comes to new drugs and treatments for AML. And rather than just focusing on ASCO 2020, I thought I would focus the majority of my time discussing updates that were presented either at the 2019 ASH or the 2020 ICAHO or ASCO meetings, or have been recently published in final form in the literature. But then at the end, I will briefly touch on where we are with the treatment of ALL in a slide or two. So as of today, there are now 9 new drugs approved for AML since 2017 that provide additions to either the upfront therapy, the treatment of relapse or refractory AML, or the maintenance therapy of AML. With these drugs available, many of them being oral agents, there's now an expanding number of alternatives to the traditional therapies used in AML. And with this, the treatment algorithm for AML, previously in place for almost 5 decades, has started to shift, and the line between intensive therapy and non-intensive therapy has become blurry. This is especially true for the upfront therapy of AML, where there is increasing interest in using combinations of lower intensity drugs, in particular for older individuals and those with comorbidities. Probably currently of biggest interest is Binaytara, an oral selective inhibitor of BCL2 that has previously been shown to be exquisitely effective in patients with CLL. In AML, Binaytara has moved into the center of attention because of data that came out from single-arm phase 1b/2 studies in which the drug was combined with either low-dose cytarabine, one of the hypomethylating agents, azacitidine or azacitidine, in older adults with newly diagnosed AML that were felt to be poor candidates for intensive chemotherapy. Both of these studies showed that such doublet therapies can be given without excessive toxicities and result in remarkably high CR or CRI rates above 50 or 60%, with activity observed across the genetic disease spectrum of AML. This is also true, for example, for the subset of patients with IDH-mutated AML. I'll get to this a little later. Binaytara doublet therapy received accelerated approval by the FDA based on the results of these phase 1/2 trials, but of course the true value of such doublet therapies has remained unclear given the uncontrolled nature of these early phase trials. This gap is now closed with availability of data from 2 randomized trials in which Binaytara doublet therapy was compared with either low-dose cytarabine monotherapy or azacitidine monotherapy. The first study reported in full form was VIALE-C, in which adults considered unfit for intensive chemotherapy were randomized in a 2-to-1 fashion to either low-dose cytarabine plus Binaytara or just low-dose cytarabine. A total of 211 patients were enrolled in this study, and many might point out that the results were quite disappointing. The study failed to meet the primary endpoint of improvement of overall survival in the planned analysis. A second analysis done with 6 months of additional follow-up then showed a statistically improved overall survival with the doublet therapy compared to monotherapy, but the median survival of about 8.5 months with the doublet therapy is certainly less than many would have hoped to see, and may not be fundamentally different what you could get with a HME monotherapy alone. Now, more positive were the results reported from VIALE-A, in which adults considered unfit for intensive chemotherapy were randomized in a 2-to-1 fashion to either azacitidine plus Binaytara or just azacitidine. The trial eligibility criteria were very similar to those of VIALE-C, except that prior treatment with hypomethylating agent was not allowed in this study. Essentially, a patient had to be either at least 75 years old or meet at least one unfitness criterion. VIALE-A enrolled a total of 431 patients, so it was much larger than the VIALE-C trial. With a median age of 76 years, many individuals were indeed older. However, over 50% of the study population has an excellent performance status, suggesting that many individuals were enrolled in this trial based on age and not comorbidities. Keep this in mind as I will go back to this in a little bit. The meat of the study results of VIALE-A is summarized on this slide. The venetoclax-azacitidine doublet results in substantially higher CR and CRI rates than monotherapy, with a shorter time to maximum response, and most importantly, resulted in a prolongation of the median overall survival by approximately 5 months, from 9.6 to 14.7 months. While venetoclax has been used widely before results from VIALE-A have become available, I believe it's fair to say that this study has cemented or will cement the role of venetoclax-azacitidine as a new upfront therapy for AML, and we certainly see an increasing number of patients that are receiving this therapy in either the community or a cancer center setting. Now, most typically, venetoclax-azacitidine is considered for adults felt to be unfit for intensive chemotherapy. However, I believe more work is needed to truly understand who should receive this doublet therapy and who benefits from it. In this regard, I found the subset analysis of the VIALE-A trial that was published in the New England Journal of Medicine both highly interesting as well as concerning. When you focus on the analysis that looked at age, you will notice that the survival benefit seemed limited to the individuals older than age 75, whereas there was no statistically significant survival benefit for those younger than age 75. When you consider that you needed to have comorbidities to enter the trial when younger than age 75, but could be in excellent health otherwise if you were older than age 75, the subset analysis may suggest that the greatest benefit will be in older, fit individuals, perhaps not the population in which the drug is nowadays often used. So clearly more data needed on this issue, and also on the comparison of how this would really compare to more intensive therapies that one could still consider for older individuals that are otherwise medically fit. Also, more data will be needed to help us understand how best to treat patients who fail venetoclax-HMA therapy. We will obviously see an increasing number of these individuals, as these doublet therapies are not curative in most individuals. A small analysis presented by investigators from MD Anderson at the 2019 ASH meeting demonstrates this issue. The study cohort was small, with only about 40 patients included who received venetoclax-HMA combination therapy and ultimately failed this therapy. Yet the study highlighted just how dismal the outcomes are of the failure of therapy by showing survival times in the 2 to 3 month range of the venetoclax-HMA failure, almost regardless of whether salvage therapy was attempted or not. So my take on venetoclax is that this drug is here to stay, and at least in combination with a demethylating agent will form a new standard of upfront care for some adults with AML. While currently used for those considered unfit for chemotherapy, I've shown you some data indicating that we need to understand more about which patients really should receive venetoclax doublet therapy, a therapy that causes profound cytopenias and cytopenia-related problems. We will also need to develop new ideas as to how we approach patients who fail venetoclax-based therapies, as current salvage therapies are usually ineffective. A second drug that has gained a lot of attention is CPX-351, which is a liposomal formulation of cytarabine and daunorubicin. Efficacy signals early in the development of CPX-351 have suggested particular benefit compared to the standard 7 and 3 chemotherapy in patients with secondary AML. And indeed, a randomized phase 3 trial comparing CPX-351 against 7 and 3 in older adults with therapy-related AML or AML with MDS-related changes showed high response rates and longer overall and event-free survival of CPX-351, especially in patients who subsequently underwent allogeneic hematopoietic cell transplantation. A study presented by Coleman Lindsley at the 2019 ASH meeting asked the question whether or not there is benefit with CPX-351 across the board of these therapy-related AMLs or AMLs with MDS-related changes. He did this by profiling pretreatment blood or bone marrow samples from about 2/3 of the participants of the randomized phase 3 trial. As you can imagine, this AML subset is highly enriched for patients with TP53 mutations, a fact I will get back to in just a few slides. Now, what he found suggests that the magnitude of CPX benefit varies across the genetic spectrum of AML. For example, there appears to be greater benefit in patients who have secondary type AML mutations, that is, mutations that characterize secondary AML as compared to patients with activating mutations. Perhaps most importantly, however, whereas there is benefit seen in some of the molecularly defined disease subsets, on this slide shown patients with mutations in ASXL1, TET2, RONX1, and DNMT3A, there really was no benefit in the subset of TP53 mutant AML, in which both TPX and 7 and 3 resulted in very poor outcomes. This finding is relevant in my mind, considering that a third of the patients considered candidates for CPX therapy based on the fact that they have secondary AML or AML with MDS-related changes have TP53 mutations. So my take here is that this study is another important reminder of just how genetically diverse AML is, and that we cannot simply assume that treatment benefits seen in a study will apply evenly to all subsets of patients represented on that study. How this study informs clinical decision-making is perhaps more difficult to see, as in most places, it takes quite a bit of time until mutation testing for TP53 becomes available. That said, Dr. Lindsley's data could be used to make an argument of expedited TP53 testing when treatment with CPX351 is considered and weighed against other treatment options, such as venetoclax and HMA, for example. Now, an interesting drug class, and one I admit I'm currently not certain what its exact treatment role is the class of oral inhibitors of mutant forms of either IDH1 or IDH2. Two drugs, ivosidenib targeting mutant IDH and enasidenib targeting mutant IDH2, have been approved by the FDA. They have remarkably similar efficacy and toxicity profiles. In patients with relapsed or refractory AML with mutant IDH1 or 2, they induce remissions in about 30% of the cases, with some of these remissions being relatively durable. As a notable toxicity, they induce a differentiation syndrome similar to that seen in APL with atra and arsenic in about 10% of patients, a fact that needs to be considered when using these agents. Now, there's no question that both of these drugs have single-agent anti-leukemia activity and are approved for that use. However, how much is gained with these drugs relative to standard AML drugs is less clear. A further cautionary note was reported by the NCRI at the 2019 ASH meeting, when a group of investigators around Robert Hill showed outcomes of patients with relapsed IDH1 or IDH2 mutant AML received standard salvage therapies that were quite similar to the outcomes reported on the single-agent IDH1 inhibitor trials. Now, of course, this is not a fair comparison to look at two different separate analyses. So a bigger cautionary note then came with the recent announcement of negative interim results from the Identify trial. This randomized phase 3 trial was planned as a confirmatory trial for the activity that was seen in the uncontrolled early phase trial, and tested enasidenib monotherapy versus standard of care regimens in older adults who were refractory or relapsed after a second or third line therapy. The primary endpoint of this study was overall survival. While there was very little information provided, a recent press release stated that this trial failed to meet the primary endpoint. We will hopefully hear an update on this study, perhaps at the upcoming ASH meeting. And of course, again, it will be interesting to see what subset analysis will show and whether there can be subsets of patients that will derive a benefit compared to standard salvage therapies, at least when it comes to survival. The IDH is also used in combination with other drugs, in particular with hypomethylating agents. Courtney DiNardo most recently provided an update on a 2-to-1 randomized study testing enasidenib with azacitidine against azacitidine alone in about 100 patients with newly diagnosed AML that were felt to be unfit for induction chemotherapy. Many patients were indeed older than age 75, of whom many had quite excellent performance status, so a population that's very similar to the one that was included in these venetoclax combination randomized trials. Now, the preliminary results are perhaps a bit disappointing in that the combination therapy was no better than azacitidine monotherapy as far as overall survival concerns. Now, it can be pointed out that the response rates were quite a bit higher with the combination therapy. There was a certain trend towards longer event-free survival, which may provide some treatment appeal on its own. However, especially with the availability of venetoclax HMA doublets, and the demonstration of such doublets have high efficacy in people with IDH-mutated AML, and considering that these venetoclax doublets do provide a survival benefit relative to HMA therapy alone, the role of IDH inhibitor HMA combination therapy in the upfront setting is unclear to me. Now, an important recent update in AML is the rediscovery of maintenance therapy. Investigators for over 40 years, a larger number of randomized trials have tested various therapies as maintenance therapy. Of these, low-dose IL-2 plus histamine dihydrochloride has been shown to improve event-free but not overall survival in this setting, and it is approved in Europe for this purpose. However, it's hardly used there, and maintenance therapy got forgotten for a while. Now, this has fundamentally changed in 2019. The first study that brought maintenance therapy back on the horizon was the ACAHO97 trial, a randomized phase 3 trial testing azacitidine monotherapy in adults older than age 60 who have achieved CR or CRI with intensive induction chemotherapy. While the study enrolled only 116 patients and was terminated early because of slow accrual, it suggested some benefit of maintenance therapy by showing improved disease-free survival compared to observation alone, although overall survival was not improved. In this study, patients were enrolled directly after remission achievement, and the role of azacitidine following post-remission therapy could therefore not be assessed. The drug that brought maintenance therapy really in the center of attention is CC486. CC486 is an oral formulation of azacitidine that has, however, a distinct PK and PD profile from injectable azacitidine. Of the early phase trials demonstrated that CC486 has efficacy against a variety of blood cancers. A randomized phase 3 trial was launched that compared CC486 against placebo adults older than age 55 who were first remission after receipt of intensive induction chemotherapy, had intermediate to high-risk cytogenetics, and were ineligible to proceed to allogeneic transplantation. Unlike the ACAHO97 trial, patients could have received some amount of post-remission therapy before entering this study. CC486 or placebo was given for 14 out of 28 day cycles until relapse or death. Now, the total of 472 patients were enrolled in this trial. Median age of the participants was close to 70 years, and the vast majority had an excellent performance status and had intermediate rather than high-risk AML. About 80% of patients had received at least one cycle of post-remission chemotherapy before starting study treatment. Now, the most important study finding, CC486, which has GI toxicities and cytopenia as its most important side effects, improved both overall and relapse-free survival compared to placebo by a median of 9.9 and 5.3 months, respectively. Although it is noteworthy that there's no shift in the plateau at the end of the curve, suggesting that therapy is curative in the majority of people in which it is used.
Sorry, Roland, I'm just going to interrupt 1 second. Sibel and Melinda, can you please mute your lines? We are getting a lot of background noise through your lines. Thank you so much. Sorry, Roland, go ahead, please.
No worries. So my take here is that CC486 is another drug that is here to stay. It is now approved by the FDA. I believe the data presented in the Quasar trial will lead to a change of practice for a subset of primarily older patients with AML. I suspect the fact that CC486 is an oral drug, that might lead to the use in other situations in which there is currently data for the use of injectable azacitidine. However appealing this may be, considering that the properties of CC486 and injectable azacitidine are sufficiently different, this may be a problematic strategy, and drug use in such situations should be first studied in the clinical trial setting. So with this, I would like to switch gears for just a little bit for the last few minutes and briefly talk about updates in ALL. Now, like AML, ALL has seen several new drugs approved, although none of the approvals has been very recent, and all approved drugs primarily focus on patients with relapsed disease or intolerance to other drugs. With CAR T cells, a bispecific antibody, and an antibody-drug conjugate, ALL has been a paradigm for the new wave of highly effective immunotherapies to treat human cancer. And undoubtedly, these drugs have found their way into the daily care of patients with ALL, even though many of them have unique and potential life-threatening toxicities, including cytokine release syndrome and veno-occlusive disease, or sinusoidal obstruction syndrome. With these treatment options available comes the challenge of figuring out which therapeutic should be chosen for which disease status or disease burden, and how transplantation still fits into the treatment scheme. Cost and treatment logistics are important considerations when trying to formulate a treatment plan for any given patient. Like in other malignancies, there are current efforts on developing new drugs for ALL. I might point out the combination of venetoclax and navitoclax, an oral drug inhibiting both BCL2 and BCL-XL. Early data suggest high activity of this combination in patients with ALL. In parallel to the testing of new drugs, however, there are ongoing efforts integrating new drugs into old treatment schemes. For example, newer tyrosine kinase inhibitors in multi-agent chemotherapy backbones. And in particular, the testing how these new immunotherapies could be used in the upfront setting. Many early phase trials on the latter have been presented in larger hematology meetings, and it's likely that treatment algorithms for ALL will change fluidly over the next few years, integrating results from such efforts. I think with this, I will stop, and thanks to you very much for your attention. Shall I hand it back to you?
Yes, thank you, Roland. That was great. Great to see all this progress happening. Let's see, do people in the audience have questions for Dr. Walter?
Hey, Salinger.
Yes, go ahead, Dave.
Hi, thanks. Roland, thank you for a really comprehensive talk. I had a question for you. You mentioned about the poor prognosis of patients who received azacitidine and venetoclax, and when they progress, you know, the dismal options available to them. There are a fair number of patients who are still getting azacitidine alone. You know, maybe they had low-grade MDS and have now been on it for a couple of years, but unfortunately are coming to the end of their benefit. And I know there's a little bit of data suggesting that trying to add venetoclax at that point is not useful. Do you have any thoughts about that small but persistent group of patients who've never seen venetoclax but have progressed on azacitidine?
No, I mean, I think it's one of these populations that we were struggling before. I mean, it's not just that they don't respond as well to the addition of venetoclax, but they also don't respond as well to the standard, more intensive AML therapies when we try to treat them with that. So it certainly either it selects out a resistant disease with the treatment, or it just identifies the people that were meant to be resistant to therapies. I mean, here we usually try to find clinical trials for them. I suspect that over time we will see fewer people that will get azacitidine monotherapy, just given that the data for the doublet with venetoclax is quite compelling at this point.
Yeah, I think your point is a good one. I'm having a patient come to you guys next week who, however, fits that right sweet spot. He'd been on azacitidine, was reluctant to start venetoclax. This was back 2.5 years ago, just as venetoclax was coming to be recognized as a valuable option. And for 2 years, he'd done really, really well and was not open to switching to venetoclax and azacitidine, but now has emerged with acute leukemia.
Yeah, I mean, it's sort of interesting. The CC486 trial had sort of an interesting thing built in that people who had low, so they were monitored over time, right? And if patients were identified with sort of low-level disease burden recurrence, and it was defined in the trial by 5 to 15% blasts, they were eligible to either receive CC486 if they weren't on the investigational arm, or to increase the duration of the treatment from 14 days to 21 days. And it's sort of interesting that this worked in about 20% of people, and it didn't work any better for people that didn't have CC486 before. So sort of this idea that just give more of the same drug probably can work in a small subset, but it's not a very likely strategy.
Thank you.
Other questions? So Roland, can you give us a sense of how much progress is happening in AML as a whole? And one way to judge that might be just the number of deaths from AML in the U.S. How's it changing? And obviously, incidence will probably play a role in there too. But what's your sense of how much progress are we making, at the population level and not just in unique subgroups?
Yeah, I mean, this comes out every few months. Is a new analysis on this, and I think that the general gist of the data has been quite consistent in that people have made sort of gradual progress in adults, particularly for those younger than age 60. Now, the most recent years, those that now see an introduction of these new therapies, those are not yet reflected in this, right? So that sort of really predates the newest wave of drugs. But there's been a general trend to improved outcomes, but that was obviously done in the setting of the drugs haven't changed all that much, so which suggests that a good portion of the progress was probably not through the new use of drugs, but through better supportive care, maybe through better or more wide access to transplant, that kind of stuff. But I think on a broader level, how the outcomes have changed with the new drugs, I think we still have to see that. The progress seems to have been more gradual for people older than age 60, although there's now some series out that also show there's some benefit there, although it's usually more modest than what people have shown for the younger adult subset of patients.
Great, and I have to actually just take this moment to make a remark, as to how some of your common sense interventions have really added to the quality of life of our patients. And for people in the audience who may not know, Roland led the initiative of discharging our patients on the sooner side from the inpatient service, and not just keeping them in the hospital for months at times. And I think even those 3, 4, 5, 6 extra days that people are able to spend outside are very, very valuable in this population that is getting very intensive treatment for many months. So thank you for that contribution. I can see when I'm attending, it definitely makes a difference.
Yeah, it certainly has helped us to have a larger number of patients treated at our center with the more limited beds that we have, right?
Absolutely.
Yeah.
Well, thank you so much.